So we've already did a little bit with end of life issues, and the last class I think we did a case study on physician assisted suicide, but we knew it didn't do a lot of lead up to it. So today is going to be more concerned with the different distinctions of physician assisted suicide to passive euthanasia, and also what the nurse's role is in any of those particular instances, whether they could participate or not. And then we're going to talk a little bit about our pandemic going on. I have a neat way to kind of like sneak that into the conversation by a friend of mine who's actually from Genoa, Italy, a bioethicist who sent me some information. I thought this is perfect for what we're doing today. So we'll take a look at that. All right. Now, I'm not saying that some of the things we'll be talking about today are not obvious. Sometimes, I hear them coming out of my mouth and it sounds like I'm just uttering common sense. But part of what we do when you try to have an education prior to go into a situation is that it's sort of like determining the best mode of action before you're in the instance of the situation. Because I remember how many times I said we don't want to leave our ethics to be developed by default. We're going to have some sort of plan in our heads so that when it happens, even if we are surprised, we can act professionally, not look surprised. So part of what we're going to try to do is how do we come up with standards and judgments to determine end of life care and when life, maybe we should withdraw or withhold particular treatment. Now, nurses have an ethical and moral obligation, according to the NAA Code of Ethics, to minimize unnecessary care. So this has to do with a little bit what we talked about in the last class about medical futility. We're just going to try to look at it a little different. What are some of the standards that we can use to determine whether or not we should be withholding or withdrawing care. Now, a lot of what we're going to be dealing with, at least you are, for those of you that, I think it's almost all of you in the nursing program, most people do not make these end-of-life determinations very clear. By that I mean they don't often give a durable medical power of attorney. They may not have a living will. They might have simply just made some remarks to their family and friends. So the surrogates and the family that's involved are the ones that you're going to be not just in proximity with, but also getting a lot of the information from and trying to make an assessment as to what would this particular individual want. I mean, if they're not able to consent, how will we solicit that out of them? So the reason why family and friends and surrogates are such a good initial choice for determining this, again, it's obvious, but let's go through it. We're going to assume that those people that are in close proximity to the patient are going to have a certain level of sharing their value systems, but also having the cultural context, right? So remember how we were talking about cultural sensitivity and how that plays out with patients. We can't know everybody's particular culture and how they understand their health care and what they would like their healthcare system to be administered to themselves. So, their family and friends are going to be advocates for them, and those in the healthcare industry are going to rely quite a bit. And also their desires. Now we're going to see, and I'm going to talk more about this in a minute, we're going to see that these are knowable, but they're also imperfect, right? So when people typically would offer some insight into their desires, they're not giving clear legal case study advice, to their spouse or to their children. If this happens to me, then I would like you to do this. But if that happens, then I'd like you to do that. These are typically things that come up within conversations. But nonetheless, those conversations are not ones that you're privy to. You're only privy to the surrogates or the family that have had those conversations. So it's through them that you'll get insights into the particular care that each of these patients may consent to. And we're also going to assume that in most cases, the surrogates and the family are going to have the general welfare of the patient in mind. There's limits to this, and we've already talked about that, so I won't be redundant. But how do we really know that they're not after Uncle Joe's money, that type of thing? But on the same hand, they probably have heard Aunt Sally say, I don't ever want to live like that. If I ever get like that, please do this, this, or that. So there's some insight there. So again, these are imperfect, but these are at least ways that the healthcare workers are going to find ways to have some sort of assessment. Again, you're trying to give care, and we're going to talk a little bit later about how we're always balancing this beneficence with patient autonomy, which you're going to be doing here too. But you do have an obligation ethically to minimize unnecessary care to the patient, and you're going to get the information through the surrogates and the family. This last marker here is not meant to be one of cynicism, but the reality is that if there is a miscommunication, or if it's perceived that you went against the wishes of the patient, it will be the families and the surrogates that take legal recourse against perhaps you and the facility. So there is that in the back of the mind. I'm not saying that should be the motive here, but the court will weigh quite heavily what the surrogates and the family have to say concerning this because of the first three criteria. They realize they share the values and cultural system, these, understanding of the patient, and also the desires and the welfare. So these are all the things that you're going to have to take into account when you try to make some sort of assessment as to the end of the life care of the patient that you're dealing with. And I'll have some stories here coming up. Now, according to your text, there's probably various standards that could be used, but there's something that you have to base the assessment on. So we're looking to a situation where the individual can't really consent to themselves. So something has to substitute that consent, and you're going to try to make some sort of judgment based on the surrogates or the families. And if you do that, what they call the substitutive judgment standard, if you use what is known as subjective standard, it's going to be based on the testimonies of what these individuals say. Now I want to say something real quick on the side about the terms subjective and objective. In our modern connotation, when we hear the word subjective, we think it's an opinion. And that's not really how we should understand it here. There is an opinion aspect to it, but we're trying to ferret out, what was within the subject. And the only access we have to the mind of that individual who no longer can consciously consent is the testimony of their particular surrogates. So that's taken into account, but this is very imperfect. The reality is these conversations, and again, if anybody has any experience with this, please feel free to chime in. But the reality is nobody sits down and lays all these conversations out with their children or with their spouse. They tend to come up in situations when we're not in a great space psychologically. Perhaps somebody in the family is in a terminal life situation. And then all of a sudden you hear the father say, well, I don't want that to happen to me. Well, what do you mean I don't want that to happen? What is that? Well, I don't want to have to live like that. But that's very vague. Or it could be that's, on the way home from a funeral. I recall a friend of mine, him and his wife talking on the way home from a funeral. If this ever happens to me, I don't want, to have to go through this or go through that. So, when we're in these visceral states, we make some sort of statements that aren't necessarily reflective of our overall judgment once we had time to think about it. So even though these testimonials that might come from family and surrogates are powerful and they need to be considered, they're not the end all. The reality is my friend who went through that, I remember like a year or so later, he wanted to talk more about it, and he said he was rethinking some of the thought, some of the way that he had at least, articulated it. And unfortunately, he himself passed away within the year. So, talking to his wife afterwards, she said, he did talk to me further about it too, and he didn't seem to be on the same level that he was when he first, made those statements. But that's part of the problem, is that we don't have context for these things. So nonetheless, it's imperfect, but it's something that's going to be added to our conversation. Now, the objective best interest test is where it's objective because you're taking it away from the subject per se, and you're trying to look at the circumstances that might be similar in other conditions. And you're trying to make a determination of what is in the best interest of this particular individual, weighing the burdens and the benefits of the treatment and the quality of life and care that might have to follow. So these are all substitutive judgment approaches, and they are imperfect, but nonetheless, they're insights into exactly how we may move forward in making sort of assessment on consent. The last one, and then I'll take, if we have any questions, this is sort of a mixed bag, right? So the limit of objective standard is going to have the same understanding of testimony. And I've read and heard that there are these, testimonial forms some people can fill out. I've never seen one of those. But nonetheless, who knows? Maybe there's something out there like that. But it's not just taking the testimony of the surrogates and the family into consideration. This is also weighing the qualitative care that is being offered and ratios of success. What will be the quality of life after this particular operation or treatment and such. So it's more objective, but you're starting to look at it more in terms of like an overall holistic approach. I was thinking in terms how these end of life decisions that we make, like we're assuming here that the individual can't speak for themselves. But even when they can speak for themselves, that condition isn't, absolute that carries on through the rest of their treatment. I'm thinking particularly of my father-in-law, who at one point was told that, this may happen while you're here, X. I'm not saying exactly what, and we'll have to intubate you. Are you okay with that? And he was able to speak and said, yes, I'm fine with that. So the condition did arise and he was intubated, but from that moment on, he was no longer vocal, nor was he conscious enough to participate in the consent of his care. So what do you ferret from that? I mean, do we think, well, he consented to that, therefore he's going to consent to the following care? We can't assume that. So, it's even a living will would have a difficult time trying to lay out all the future happenings. I've shared with you before in class, and one time I was talking to a physician when my mother was in the hospital, and he told me he was quite clear on what his treatment would be in given scenarios. And had to do with percentages. If he had X amount of percentage hope in this, and the recovery was going to be this long, and the particular quality of life afterwards would be such and such, then he would agree to that. Well, I don't know how you could do that in the complexity of medical conditions that oftentimes people find themselves in, where it's multiple systems that are involved. And plus, like I jokingly said to him, do you plan on having an accountant in the room when all this is going on? Because who's going to lay all this out? So, outside of somebody having durable power of attorney, which is obviously the best, you're always going to have some imperfect system. And you have an ethical and moral obligation to not give unnecessary care, but that doesn't really solve it, does it? Because how do we determine what is or is not unnecessary? We're back to these terms. And how do we really know what the person's consenting to? We always have to weigh in whether or not somebody has an ulterior motive. Who knows? Maybe they want Uncle Joe's money. Maybe they didn't like the person. It's impossible to say in these circumstances. So we're going to come back to this at the end and talk about some of the real basic ways that a nurse could ferret out some of these things from a patient. But do you have any questions on that per se? Trying to stretch this out so I could see as many of you guys as possible. All right. Okay. Now, when we talk about euthanasia, I'm going to lay out the various forms of it and physician-assisted suicide. I'm trying to give you an understanding of what the variant characteristics are for different types of euthanasia, but also to show what is or is not the limits of the nurse to be involved in this end-of-life care, and at what point can they no longer cooperate ethically, at least according to the ANA Code of Ethics. All right. So the reality here is, I'm sorry, I'm moving you guys around on my screen a little bit. We're always in this zone where we're trying to determine whether or not to continue or cease care. So do we withdraw particular care that's ongoing and is either futile or the patient is no longer consenting to it, or do we withhold care up front? That could be, at least in this particular instance that we're talking about, end-of-life issues, that we're withholding care that would obviously preserve a person's life. So involuntary euthanasia is, and this doesn't matter if it's active or passive, right? So active is if the physician gives, like, say, an overdose of morphine that they know will terminate the individual's life. Passive would be if you withhold or withdraw. If it's involuntary, it's homicide, right? So this is not really an ethical dilemma here. It's a breach of ethics if this happens. And does this happen? Oh, I'm sure, because no particular vocation is void of having individuals who do malicious things. But that's not really something we're concerned with talking about. If somebody is doing something against the will of the particular patient and that act ends in their death, that's homicide. So we're going to leave that as off the table. So let's talk now with voluntary euthanasia. Okay, so voluntary euthanasia could be known as passive, and this isn't, when you hear the term euthanasia, you're not typically thinking of it this way, but the text presents it this way. It's not usually used colloquially. We would just say that we're withholding or withdrawing treatment, but technically, because it results in the death of the individual, and the individual is involved in that, and euthanasia does mean good death, we're addressing it here. Now, the problem here, not problem, but the criteria here is that the intention is not to will the death of the patient. So we've already talked about the principle of double effect a little bit. We're going to come back to that in a minute. But what we're talking about here is accepting the inevitability of a person's mortality. In other words, we all know that we're going to die. We all know at some point treatment's going to be futile, or whatever treatment it's going to have is not going to be proportionate to the quality of life they will have after the treatment's over. So we're just going to accept the fact that this will be the end of our life. So you withdraw treatment. It could be, I read a case study once, it was an individual with cystic fibrosis. Now they've come a long way with this, but back in the 90s, people might only live, hopefully, to like the mid to late teen years and such. So, if a person goes into respiratory distress, at what point do you no longer try to intubate and keep them alive? So to say, I don't want that, we would not consider it technically euthanasia, but they're calling it passive euthanasia in the text, and we'll leave it at that. But I want to be very clear that what makes this distinguished from physician-assisted suicide is that it's the intention. The intention is not for the person to die. The intention is simply to allow the underlying, well, let's put it this way. The cause of death is not the medical intervention or lack thereof. The cause of death is the underlying medical condition. That person has just simply made a determination to not consent any longer. Okay, we'll leave it at there. Active would be if a physician says that I will give you a lethal dose of morphine. In other words, the difference between, remember we said that under the principle of double effect, you can give morphine that would hasten death. If the morphine that was given was proportionate to the amount of pain that the individual was experiencing, but giving this morphine, that would quicken death, that's still not physician-assisted suicide, nor is it unethical. All you're doing is you're treating the person's particular, discomfort of the pain, and you're realizing that this will hasten their death. But in all circumstances were different, you would not want them to perish. But in active voluntary euthanasia, you're giving the individual enough medication purposely for the death. I mean, that this is going to end in their death. They've chosen it. It could be, I'm old enough to remember with Dr. Kevorkian years ago when it was all in the papers and there was all this struggle about what he was doing per se. What he would do is he would have an individual and he would set up an apparatus where the individual can actually release the medication through an IV into themselves. So he would set up to make sure that it was medically safe, if you want to say it that way. I know it might sound ironic that the person was dying with the result of it, but nonetheless that there was nothing going to be haphazard happening where the person would experience prolonged discomfort, and he would make sure that everything went perfectly fine and the individual would take their own life. So that was his way of trying to get around the legality of he did not do it. He just set it up so that he allowed the other person to do it, but we won't get into parsing that. But it doesn't matter ethically either way, that's physician-assisted suicide. Whether you're good with it or you're not good with it, that's an entirely different point of view. But it's physician-assisted suicide at this point. We would consider that distinct from the passive just by the intention. Has anybody here ever read Viktor Frankl? Do we know who Viktor Frankl is? He's a famous psychologist. Wrote Man's Search for Meaning. It's a very popular book. It's used a lot of times in ethics courses. It's not a religious text. The difference here is, we struggle with these issues. The reason why I think a lot of us don't even want to deal with living wills or assigning people durable, no, forget about that. Just, talking with other people about our direct preferences is that even though we know we're going to die, we just figure it's not going to happen today. So we don't handle suffering very well. In other words, we're going to talk a little bit about the pandemic that's going on now, and a lot of people's issues with any sort of deity is how can something that's bad happen to good people? Why would a benevolent God allow things like this to happen? Well, Viktor Frankl worked out a syllogism, and we've studied a couple courses, a couple of days in logic here, so we know how to build a syllogism and make an argument. And Viktor Frankl's idea was this, that life has meaning. Now, I think most of us would accept that. We might argue about what the meaning is, but we know that life has some sort of meaning. He then comes up with the second premise that suffering is part of life. Now, none of us would, discredit that. So if life has meaning and suffering is part of life, therefore then suffering has meaning. Okay. So I guess that doesn't solve our issues, because what meaning does suffering have? Well, we're not here to work that out, but it's part of life, and so is death. And the reality is that life would not have a lot of meaning if it didn't have a finality to it. If we knew we can live, 10,000 years, we would live differently, knowing that, on a good day we'll make it to a century. So there's something about the finality of death that makes what we're doing seem to be worthwhile, and makes our pursuits, seem to be valid, valid concerns, at least to evaluate, to make sure that we're doing well, right? That type of thing. So there's a difference then, once you've come to accept the finality of our own lives and the fact that we're all mortal beings. There's a difference between accepting that and allowing the underlying medical condition to have our life end, and actively pursuing that end. All right. So physician-assisted suicide and Dr. Kevorkian, the reason why they would call it mercy killing, is that some people would take these particular, let's put it this way, they would take things in their own hand. If the argument is, if they don't have access to some sort of medical and sensible means, if you want to call it, I know it sounds weird to call it a safe means, but a way that they would not otherwise fall into some coma, state of a coma, or if they did try to kill themselves, if they were unsuccessful, how would that leave them? So the idea is to help them along that case. Somebody in the class before you said he was in the emergency department, and they resuscitated an individual with multiple gunshot wounds, and after they were able to stabilize him, realized that it was a suicide attempt because he has terminal cancer. Now, was that the ethical thing to do? Well, of course it was, because first of all, it's an emergency situation. You can't really ferret out consent, and secondly, your job is to sustain life and restore health. Whether or not the person has a year to live or such is not as deep, it's not a characteristic that's going to make a determination on your ethical approach. But the reality is, and then I want to just see if you guys have anything to say on this. The reality is with this type of understanding in the nurse's role, particularly, we'll mention in a minute, is that there are 6 states within the United States that have some sort of laws that allow this. I didn't want to get into it because we're not lawyers. I'm not a lawyer. And the situation differs depending on the state. Typically, you have to at least be 18 years of age, 6 months or less to live. It has to be terminal, of course. You have to obviously have no underlying clinical depression or such. There has to be maybe psychological testing. There's various things. But even those things are sort of arbitrary. I mean, if we say that a person has to have 6 months or less to live, why 6 months, right? I mean, why not a year? What makes 6 months, the magic date? So if a person had such moral distress over, the fact that they have terminal illness, and that, maybe they have stage 4 pancreatic cancer, and the likelihood of me making it a year is 5%. I can't deal with that. Can I go now on my own terms? So these things tend to be stretched. We looked at the fallacy of slippery slope, but remember I mentioned that it's not a fallacy just per se. It's only a fallacy if the causal links between the connections are not valid. In parts of Northern Europe, an individual was going blind, didn't want to live a life of blind from his age 40 something on. So he was granted the opportunity to do active, it was physician-assisted suicide. Let's leave it at that. There was even one who was an 18-year-old male who was clinically depressed. He was lucid when he was making these decisions, said the court, but he did not want to have to live a life dealing with this type of illness. He could not foresee the struggles that he went through just in his teenage years extending out until he's 60 or 70. He's had no other health conditions. So he was allowed to terminate his own life. So, once somebody starts arguing the right to life, I'm not saying per se it's a slippery slope, but you get very difficult on how to make these particular decisions. Anybody have any feelings on this? Anything you want to share? No? You could chime in. it's tough too because, you know, the reason why they even put time, like when a person does make a determination that they would like to like pursue this, it's hard to say that somebody would not change their mind. I want to leave it at that. I actually have some case studies in my mind, but I'd rather leave it at that than go through them per se. Anything else on that? Okay. Let me try to shrink this window a little bit so I can see more on my screen. Okay, I wanted to share this with you guys because I thought we're in the middle of this pandemic and this would be interesting, hopefully, for some topic of discussion. And we're all going to do a text to polling before we're done here, too. Okay, so in triage, you're always trying to do the best you can with the limited resources that you have. And resources obviously would include personnel, doctors, nurses, and such. It would include access to equipment. It would also include pharmaceuticals, the ability to care for the people that are, that you're placed alongside. When you get into some particular instance, like we are now in a pandemic, I'm thinking particularly of Italy, what do you do when a system's overrun? Remember how we talked about there's always a tension between patient autonomy and beneficence? At what point do you allow the patient to make a determination that goes against their own particular health? Because remember, the fact that it's irrational is not a reason in itself to not allow them to consent. But the principle of beneficence says that I want to do what I can for these individuals. And there's a tension that has to be worked out there, and maybe this pendulum swings a little bit. Well, in any type of triage, and particularly with the advanced directive triage, because here we're talking end-of-life issues, there's going to be the same sort of tension that lies between beneficence, the healthcare workers wanting to do the best they can for their patients, and justice. So remember, we define justice in a very general sense of to give another their due. Now, that could be individual justice, but it could also be societal justice, right? So you have to be concerned for the overall group as much as you have to be concerned for the individual that's in front of you. And if resources are limited, you at some point you're going to be making determinations on who will and will not receive treatment. And if it's advanced directive triage, we're talking about this decision is going to wind up with the individual perishing. This is really an element of moral distress for the healthcare workers. You may have heard on the news, and I'm not privy to any information, but you may have heard on the news, whether it's true or not, that doctors are allowing elderly to die in Italy. Okay. I don't know that would be untrue, but it wouldn't be because they're willing them to die. It'd be because they have limited resources, and there's only so much they can do. In the same way of any triage, if somebody were to come in, you're going to make a determination on how well can I treat this person given the circumstances that I have and everybody else. If a plane, crashes and there's 80 survivors, the triage team goes in there and starts to prioritize. And part of their prioritizing is not going to be the people that are worse off. It's going to be people that are worse off that they can actually treat. And it could be that there are people, for whatever underlying conditions, that their treatment is going to be either, it may not be futile, but it's going to hamper the treatment of other people that are put into their care. That sounds almost like what some people have used in I think a pejorative sense, a death panel. Regardless of how you feel about universal health care, I don't think it's fair to say there's going to be a death panel determining who gets and does not get treatment. But we also have to realize that resources are limited, and wherever there's limited resources, there will be some people that will be determined that, we're not able to treat here. That's difficult. Now, we don't know what's going to happen in the United States with, COVID-19. It could be that we're only, 3 to 4 days behind Italy. Maybe the fact that we're all isolating like this will stave it off, and everybody's seen those graphs, we could stay below the curve. It's impossible to say. But some of you, I remember talking to about the video from the 1918 flu epidemic, where roughly 1.5 million people died. All right, so it was a type of flu that they didn't really know. There was no antibiotics back then. They didn't know really how to treat it. They didn't know how things were, transmitted and such. Nonetheless, though, in the United States alone, it killed 675,000 people. Now, there is no way that the healthcare system at that time could have treated all these people. once you've acquired this disease back in 1918, you basically had 60 to 90 days to live. And unfortunately, it went after the younger and healthier, which is kind of odd because why it didn't affect the elderly is a little unclear. They think because perhaps they were exposed to it before and built up resistance, but they really don't know. That's speculation, even if it might be true. But it also affected pregnant women statistically high. So what do you do? When you have X amount of resources and you have all these people coming in, you're going to have to make some pretty good decisions. And it's not going to be easy. And just like when our particular epidemic, our pandemic here, right, we're all hunkered down and hopefully we can break the chain of spreading this. But what do we do once we get a little bit of green light and everybody starts going out? We're probably going to have a second wave of this. Let's hope that doesn't happen, but it's likely. The reality is that's what happened in 1918. So for those of us that are still in the Philadelphia region, everybody else that had gone home, just in Philadelphia, I think in 1 week, 4,500 people died just in the 1 week from the second wave. I'm not sure the hospitals can handle that today if it was something that big. So they're going to do advanced directive triage. They're going to start trying to determine who is it that we help. But the difference between this and simply, willing a person's death kind of fits in with the end of life decisions. It's one thing that, let me put it this way. I wish I could have got the exact case study. There was this small clinic right on the Mexican border. It was on the United States side of the Mexican border, where it was just a couple people. I think it was like an RN and someone else. They were just running a small clinic, and they had a $100,000 operating budget. And they had an individual who came across, and I'll use the word illegally just so you know he didn't come through immigration, but it was a teenager that came across the border and showed up on their clinic, and he had a rare form of cancer that was curable. But he knew he had to come here to have this cured, but the treatment was $50,000. And the company had to make a determination, what do we do? I mean, we can use up half of our operating budget with this one individual. Or we can help, upwards of 2,000 people that come across the border in other ways, with immunizations and everything else. This is difficult. We would not want to be the people making that particular determination. But nonetheless, I'll leave it at that. What we're trying to weigh here in these particular directives is the beneficence of the individual. What good can we do? But we owe something not just to an individual, society overall. That type of thing. So the way that you would try to consider this is by the intention. It's the same way that we're trying to make a distinction between passive and active euthanasia. The person who's withdrawing or withholding treatment is not intending the person to die. They just realize the death is imminent. So it's an acceptance of a person's mortality, and it's the underlying cause of the disease that is actually the cause of the person's death. That would be in line with what's happening here. In a perfect world, we'd have enough staff, we have enough pharmaceutical and enough medical equipment and such to rally and overcome whatever it is, the disease that we're trying to, that we're up against. Let's leave it at that way. But you're not. So you basically are just trying to do the best with what you have. So there's a difference between this type of triage and physician-assisted suicide, where the intention would be that the person dies. Yes, maybe there's some sick physician that gets a kick out of this, but that's the difference. Let me say this. The reality is that these things don't look too far apart from the outside. If a person is not treating somebody because of limited resources, or not treating somebody because they don't want that person to have treatment, it looks the same as far as the action is, playing out. What we can't see is the intention. So we can't really make judgments on this, but ethically we can say which one would or would not be ethical in this particular instance. Does that make sense? I never know how this stuff sounds when it comes across. Let me just scroll through the window here to make sure everybody's shaking their head, because I can't see everybody at the same time. Okay. Now, again, I think these are rather obvious points, but they're points that need to be said. So I think particularly since the nurse has an ethical obligation to not give unnecessary care, which means that you're going to be in proximity of these patients and be part of the situation, you're part of the conversation that's going to help them assess. So even with the testimony of the family and friends and other surrogates, you have to develop some sort of keen awareness to the particular wishes and values of the patient. How do they feel about this? So these aren't always sit-down conversations. The physician certainly comes in and does this, but you're going to be part of the team that's going to be next to this individual for quite some time, and you're already aware that oftentimes the patient feels much more comfortable around a nurse than they might around a physician. You seem to be more approachable and such, and you're in more proximity. So those are things that you ferret out as part of a conversation. But the second criteria here might seem a little odd, but it's pretty important to help them understand the illness progression. Everybody is always fearful of what they don't know, and you may be, after 5 or 7 years in a particular field, know exactly, once a person is at this stage, how it's going to progress. But this is the first time for these patients coming in. They don't have that foresight that you have. So they're not quite sure what's going to happen. If they're told, well, look, we're guessing that you might have 2 or 3 weeks, but don't want you to have to be fearful about the pain, because we're going to make sure that you get adequate pain medication to take care of that. That may not be their whole question. Their question might be, do I lose consciousness because of the medication that you're going to be administering? When will I lose consciousness? Will I know before I lose consciousness? Will I have an opportunity to say goodbye? These things all become part of the fears that individuals have. And even with the family members involved, they may not always know exactly what they're acquiescing to. They might say, yes, I think you should do this, but they're not quite clear, like, how is this going to progress? I'll give you, for instance, and this is where you're going to ferret this type of thing out. My cousin, who was very intelligent, he was a stockbroker. When he was 50 years old and had terminal liver cancer and only metastasized, I remember him coming to me and saying they're thinking of using this one clinical trial drug on me. It could extend my life 6 to 8 months. I wanted to talk to you and think if it's worth considering. Well, when there were very little side effects or different from the chemo he was already being treated with, I could understand why is this a dilemma? Why would you not want to do this? So he said, okay, I think I agree. So we went down to the particular, I was driving him to his chemo treatment, and we were going to administer this this particular procedure. The nurse said, did you think about this? So we're going to do this, right? And he goes, yep. He goes, we've decided that we're going to give this a try. Well, just the way that he phrased that really made that nurse a little nervous, because at one point she was now questioning, does he understand that this is a terminal illness and we're treating a terminal illness? We're not curing anything. So I remember her getting on the floor and kneeling in front of him and said, you do understand this is just a treatment, right? And he goes, yes. He goes, you do understand this is not a cure, right? And I did say something to the nurse to the effect that it's his style. He's very formal. He would talk to his own children like this. So don't take that as whether or not he understands what's going to proceed here, right? But nonetheless, and even the family, you're going to be in with this on the family, because when he finally went into hospice, I think it was in there like 2.5 days before he passed away. I was sitting with my aunt, and when the nurse came in, and one of the ministers who was the chaplain on duty came in, and they were just talking about how they would be here, obviously, and they're going to make sure he's comfortable until he passes. My aunt had this shocked face and then turned to the nurse and said, "Are you telling me there's no hope?" Well, the nurse looked back at us like, did somebody not explain this to her, that he's in hot? It was almost like she was having this moment where she probably understood it but had to deal with it, right? So, helping a person understand how the illness progresses is overcoming the fear, which is half the battle, right? We almost will accept the terminal state of our mortality, provided that we have some idea of the conditions upon which it's going to play out. But nonetheless, and then finally on that point, to balance treatment, just to make certain that the individual knows that we could do this, but the quality afterwards will probably be this. In other words, you're giving them as much information again, so that when they are consenting to something in this end-of-life treatment, that they're consenting to something that's going to be within their desires and their hopes and such. And this only gets more complicated if you're not talking to the patient themselves, but you're talking to the surrogates or the family. it gets one more layer that a person has to work through. Okay. Last but not least is you've got to be the best listeners in the world. And again, I realize that probably sounds like it's just obvious and why we have to talk about this in an ethics course. But you're going to have to exude confidence even when you don't feel confident. You know what I mean? I'll give you a scenario that has nothing to do with ethics per se. My wife, in her business, she had a retail store, and I was over there helping one of my daughters work the register. Well, she was a teenager, and she was getting a little confused with, my hitting the right buttons and then giving the right change. So I told my daughter, I said, I don't care if you hit the wrong button. I don't care if you don't even know what kind of change to give the individual. You never let the customer know that. Because the minute the customer assumes that you are not doing something competently, they get concerned that they're not going to get the right money, they're going to be overcharged, and so on. So work it out, but look comfortable as you're working it out. Well, the same thing here is that you're going to build confidence very quickly, as everybody does in their particular vocation. But nursing is not unlike teaching in a sense. It's a performative art, and that it takes some opportunity to develop the skill. So no matter how confronted you are with new information that you're not quite sure how to assimilate, that doesn't get relayed to the patient in your facial expressions, right? Because they're going to be looking at your eyes for everything. They're going to be looking to see how stern you are in your face and such, right? So the first point there may seem a little silly, but it's not. Do they know that they're approaching the end of the life? Because there's no flat out, top of the pyramid where now you're going down the other side. Or at that point, it might be obvious to everybody. But at what point is our treatment deemed futility? Remember we said, is it 5%, 10%? And then if we make this a 5%, how long does it go until it's not effective? At what point am I realizing that there is no other hope for me? So it's that moment that gets a little difficult for individuals. And you're going to have a lot of insight. Over the course of 5 or 6 years, you're going to see probably so many scenarios that you're going to be able to use that to help you make a really good assessment and help the individual identify when they might be approaching, when there is hope. Because if there is hope whatsoever, even if the hope is not for a cure, but for a good quality of life, you want to be able to relay that to the individual. But you also don't want to extend that to the point where it's perhaps at this time you should have your affairs in order. Again, you may not be given that information, but you're going to be there when all this is being lived out by the family and such in the rooms, okay? And then help them and enable them in this decision. Once they've reached a decision, help do everything from communicate that to help, ferret out whatever other fears there might be present. I'm trying to think if there's anything else before we do our case study. Nope, that's it. Questions? Anything? Let me see if I can make this big so I can see everybody.
I have a question.
Yeah, go ahead.
Can you just quickly explain what advanced directed triage means?
Okay, so we know what triage is, right? Where you're trying to assess who you can help. Okay, so all we're talking about is using triage when things are terminally ill. So in this particular instance today, like in a pandemic, you might have to make determinations where these people are 89 years old and have contracted this disease. We could probably keep them comfortable, but if we put our resources here, we might have to give up giving resources to 5 other younger, healthier people. It sounds terrible. I'm glad you said. Well, anybody else? I want to say something else about that. But does anybody else have any questions?
I was just gonna ask: is that in the case of organ donating, how there could be someone on the organ donor list for 10 years and they're gonna get an organ, but then if someone who they think is better fit for it will get it over them?
Absolutely, because you're limited resources and you're trying to do the best with what you have. So I remember Governor Casey, who was a governor in Pennsylvania some years back. He went on the organ donor list for a heart and lung, and he got 2 lungs and a heart fairly quick. Well, you can only imagine everybody was suspect. Oh, okay, he's the politician. But the medical team came out and said, no, the reason why he got bumped up was because he needed both, and both became available. So somebody might have said, well, couldn't you give a heart to one and lungs to the other? But it was just the opportunity that they made medically that we have a heart and lung that match, and they both match this individual, and this was the best fit. Did that result in somebody else's terminal death? Probably. But you need to make that decision. A friend of mine who just died of He contracted hepatitis C through a blood transfusion back in the 1980s, and they pretty much is a treatable condition today. But he had just died in the last few months. But you have complications from that, even if it's treatable after like 30 some years. I know that sounds like it's forever, and if somebody told you had 30 some years, you might not think about it. Neither did he when he was in his early 20s. But by the time you hit your 50s, it's upon you. So he was to the point where he was in kidney failure and needed a transplant, but it just did not get one. He actually died because he fell before the transplant, but he probably would not have gotten the transplant anyway. So yeah, we're limited, right? And there's only so much that you can do. So even in a case like a pandemic like this, you're going to have to determine, if we want to quantify to make the image, I have 100 things that I can do. Do I give it to one person who uses 50 of them, or do I give it to 50 that use one? Now, I want to say this because when I teach like a plain ethics course, people get confused between this, because is this consequentialism? Is this the end justifies the means? And how does this differ from the principle of double effect? Let me say this. In the 1960s, since consequentialism this isn't a Catholic point, but I'm using it to make the point, because consequentialism went against Catholic morality. There were Catholic moral theologians in the 60s that tried to develop an ethical system that used those principles, but not in the same way, and it's called proportionalism. And then if you ever heard of situation ethics, that was also consequentialism, but based on love. But proportionalism is really weighing out the benefits and the burdens. So you're trying to do the most good with what you have. Now that sounds like that applies here. But the problem is proportionalism, as we said with consequentialism, if you're trying to say that I don't care how I get to the end, you don't always know what all the consequences are. So even in proportionalism, like in this particular instance, we could say it's better to help 50 instead of 1, but we have no idea what all the criteria are there or how this might affect society overall. The difference between crass consequentialism or egoistic consequentialism and the principle of double effect, which has proportion as one of the criteria, it all comes down to the intention. The intention of the proportionalism is that you're trying to do the most good for the most people. The intention here is that you're working with limited circumstances. It's almost like your hands are tied behind your back. If your intention, it's closer to, well, it's more like passive euthanasia. You're accepting the inevitable. But in a perfect world, you wouldn't have to do it. In a perfect world, the consequentialists might do the same thing because they're not concerned with the means to get there, right? Because whatever the end is, that's consequentialism. It justifies the means. In the principle of double effect, you're very concerned with the means. It's just that you realize that there's going to be some bad effects that come from this, and we have to accept that as part of life's finality, right? That type of thing. Does that help at all, Julia? Okay. Anybody else have a question on that? Yeah, go ahead, Susan.
If we don't return back to school, what are the dates of finals?
Oh, well, we'll talk about that, but right now I have no idea, except that it'll be online. So my guess will be like, okay, I'm glad you kind of brought that up. We're going to do a poll to texting here shortly. So some of these questions are going to be what I would think a little vague. And that's probably what I will do with you, like in a case study. So I'll leave it vague enough that you have to describe it. So it'll be something, if I had to make the call right today, it's going to be online, just like your midterm, but timed. That's probably what I'll do. I'm just withholding making any determination on that because, one, I don't really see us going back, but who knows? If we go back, then life's solved. And if we don't go back, I at least have a few more weeks to think about it until then. But that's my guess. So I don't want you to, it won't diverge too much from the midterm. Okay? Does that help? Does that make any sense, Susan? Okay. Anybody else? Okay. Let's get out your phones. And let's do a case study. Now, we're going to try to determine whether or not this particular individual is just after a good death or it's physician-assisted suicide. All right? So, it's a real case study. I just kind of spiced it up a little bit. And by me saying it's a real case study, I can tell you what happened in the end. Okay? And I promise you a good ending on this. I think we're all in the mood for a little good news, all right? So Tom was an 83-year-old who had several medical problems, and he had been in and out of the hospital the last 3 months. He used to be very independent. He's been a widow for some years, but he did have a lady friend who he was quite close to. And he had 5 adult children, numerous grandchildren. Doesn't see them all the time, but they're at the holidays, so they're present. As far as the medical staff is concerned, Tom is in sound mind. He has no real history of depression, so we're not concerned about the soundness of his mind as far as consent. But we still have a problem, right? Tom's in his 80s, and life is not what he thought it would be. Anyway, when he came to the hospital, he lamented to the cardiologist, Dr. Desmond, and she happened to be on call, so that worked out. And he just said to her, he goes, look, my body's worn out. I'm worn out. I don't want to do this anymore, Doc. They say that I can't go home from here because it won't be safe. So even though he had his family and the lady friend help there for support, he went and told his cardiologist, he goes, I'm not going to a nursing home. No way. Stop this little gadget that shocks me and this part also that keeps my heart going. I want them stopped. Yes, the pacemaker too. Can a magnet do it? Just do it, please. All right. So he had this cardiac resynchronization therapy defibrillator implanted by Dr. Desmond a few years ago. And it had also an electrical pacing component for his heart rhythms. And he was 100% dependent on that. The defibrillator actually had shocked him and more than once. And actually just before he came into the hospital to the emergency department. And for him, that was the last straw. He wants no more shocks. He's obviously not going to a nursing home or rehab or any hospitalizations. He's tired of that and he's tired of the medications. And he wants no more medical pacing device. He just said, I'm tired of fighting. So the question that I have for you is this. Oh, you're going to have to excuse me a second and allow me to clear all my responses. I don't know where it archives them. I never look at them again, but it seems the only way they'll allow me to get rid of them. Okay. Okay, so if you can just go to 2 2s and 3 3s and then just text Stephen Boynell 595, you'll be back in. And then the question is, can the cardiologist grant Oliver's request by simply deactivating the internal defibrillator? Or does he need an ethics consultation in this decision? We have a horse race. Okay, so, this would be the type of question I'm going to try to generate. Because in reality, I probably would accept B or C depending on how you justify it. Okay? So let me just talk about that real quick. Here, it's not really clear what constitutes a part and what is not a part. And what's the distinction between something that's inside and something that's outside. If it's outside, we know it's not a part. If it's inside, is it a part like an organ's a part? Is it a part like an artificial hip's a part? So we can probably at least call it an integral part, even if we're not going to call it, an integral. We'll call it an integral medical device, even if we're not going to call it an actual part of the body. But the reality is, it's not clear whether or not this would have to go to an ethics board, but it's the safest route. In this particular instance, this case did go to an ethics board. So if I had to say the best answer would be yes and no, but I'd also think that no would work, provided that you just, articulate it a little bit like that. Any questions on that? Or do you want we can walk through this and you get asked too? Because I know last section somebody asked a question and it was actually the next slide. So let's try that. Okay, so then Dr. Desmond relates to the rest of the staff. He says, look, if Tom doesn't want to be shocked again, that's his decision. And if it went off again after he requested that it stopped, then we remove it. Oh, you don't see that, do you? We got to flip these. There. Sorry about that. So if it goes off again afterwards, Dr. Desmond's wondering, couldn't this be a type of battery or a type of torture, right? But then again, deactivating, they already deactivated per se, and a DNR was put in place. So she's wondering, if I reactivate and it goes off and it went and he didn't consent to it, would that count as torture or even battery? So that's the question I have for you then. Would forcing Oliver to retain the defibrillator as an implant after petitioning Dr. Desmond to remove it constitute battery or torture? Am I training you guys to always pick C? I would say the best answer here is A, yes. Although yes and no could be. Now the reason is this, is that if the anticipation of the shock, whether it's physical or emotional distress, and he's specifically not consented to it, in other words, I don't want this, you're almost bound through patient autonomy. Remember, it doesn't have to be a rational choice. It just has to be a choice made under the right conditions. So he would be given uncomfort, whether we want to term it torture or not, who knows, right? Yes and no, maybe you'd make the case that perhaps the individual should be aware that, there's going to be some sort of surprise, and maybe if we just thought it was psychological and we got you over the psychological hurdle, that maybe it wouldn't be such a big deal. But I'm not quite sure about B. It's really going to be his call. And it's not enough to say, hey, look, all treatment comes with discomfort, so therefore you have to accept it. Remember, patient autonomy is going to give him the options to get out of this if he wants. Anyway. Okay. So, Tom Oliver, he wants Dr. Desmond to also deactivate the pacemaker. So we're beyond the defibrillator at this point. He tells her, he says, I want it stopped. Now, deactivating this device doesn't have the same psychological distress concern that the defibrillator has. So it's not like you can say, I'm concerned about being shocked. But deactivating the pacemaker is different in that sense, all right? So at least keep that in mind as we try to look at this particular element of the case. Now, by removing the pacemaker, is that ethically respectful of the patient's autonomy? Okay, I think A here is the best. I think C, again, with some qualifications. I'm not sure that there's an ethical dilemma between the external and the internal. Legally, I couldn't say, because that could depend. But if a person simply, signed the DNR, that would be the equivalent to this. They're accepting the finality of what it is. So you really can't use that procedure, or in this particular instance, the technological intervention, without their consent. C, yes, it is true that one is a restorer of life, another one sort of maintains it, but those are not, they're not really the criteria that's being used here to determine the ethical, how we move forward is ethically. Remember how we did that one case where the motorcycle driver had a note in his pocket, and such. we're in that same situation, but only here it's clear. So, for instance, I read this one story. I guess it's like a medical school, running joke that you should get DNR tattooed on your sternum. So that way, if you're ever in a situation and they're going to try to resuscitate you, they would rip off your, shirt, and as they go to apply either the defibrillator or CPR, they realize, this person doesn't want a DNR. So I actually read a story where there was a lay person asking a doctor, would you honor that? And the physician said, if I ripped off a person's shirt to administer CPR and found the DNR put on their sternum, he goes, all I would use that tattoo for is a good indicator exactly where I should put my thrust. He said it has no, ethical weight whatsoever. But in this particular situation, as long as we know that Oliver he's not under the influence of any sort of pharmaceutical that's going to cloud his judgment, and he's not suffering from clinical depression, he has been very explicit that he does not want this. So this would be the equivalent of signing a DNR. So A is really your best answer. C, maybe depending on how you would word it, but B, no, he's strictly consented that he's okay with the finality of this. Okay, one more question, and then I'll show you how it wraps up. So if we stop the pacemaker, Mr. Oliver, this is his cardiologist saying, you're going to die within a few minutes. And he replies, I know, I'm tired of fighting. So, if Dr. Desmond carries out Tom's request, is this physician-assisted suicide? Now, this is going to have a strict answer, okay, so there wouldn't be a lot of leeway on this. Okay, now this is B. This is passive, all right? So this is like withholding or withdrawing treatment. It's not physician-assisted suicide because of the intention. Even though death is foreseen, the Dr. Desmond here is not intending the person to die. Just it's realized that it's going to happen. It's a choice the person's making with full consent. It would require the intention of the individual or some sort of means. In this particular instance, I'm not even sure. They'd have to give like high doses of morphine in order for this to qualify for the physician-assisted suicide. But interestingly enough here, and I'm glad it just came to my mind, I forgot to say something. There's something on the wrap up about the nurse's role in this. According to the ANA Code of Ethics, a nurse is not allowed to participate whatsoever in physician-assisted suicide. All right? Now, if there's some legality in a particular state under a particular situation that I'm unaware of, that's fine. But that's how the code reads. You absolutely are allowed to participate in the withdrawal or the withholding of treatment. So that would not be considered physician-assisted suicide, or a nurse would not be allowed to be part of that process. But that's just accepting the mortality of the individual and the inevitability of death. And the difference there would be that it's not what your action was that caused the individual's death, but the underlying disease or medical condition. You simply allowed it to take its course, which would be different from administering a type of drug or taking an action where that itself would lead to the individual's death. Does that kind of make sense? Okay, let me tell you how it ended, and then we'll see if there's any questions. Maybe you won't find this to be a good ending. I thought it was a good ending. So finally, there was an ethics consultation, but they landed on the side of patient autonomy. Figured he had full capacity to see what was ahead of him. So he had his wishes respected, and he died peacefully surrounded by a family and friend who read scripture or offered prayer. His priest had come earlier and gave him anointing of the sick. And while he died, according to the testimony of the person who put together this scenario, he sat by his lady friend's side, and she said, we had a lot of good years together, and you suffered enough. I'm willing to let you go. And Oliver's last words were thank you. So whether you find it to be a good ending or not, he did get his wishes and he went on his own terms, and he didn't have to go by his own hand. So there is no ethical dilemma. So is this physician-assisted suicide or a good death? It's a good death, which maybe is the best we can hope for sometimes, right? Okay. Questions on anything? Questions on what material we went over today? Questions on anything that's up ahead?